Hello, everybody, and thanks for having me here today. It's really exciting to be here and get to hear from so many great speakers. I will start off with just having one disclosure before we get started, and that's unlike the prior speakers who all have specific expertise and training in infectious diseases, I am not an infectious disease physician. And in fact, if you were to go back to med school and ask people what they thought I would be good at, I almost failed microbiology, so it would definitely not be anything to do with infectious diseases. So I lay that out at the onset just to say that I'm never going to be one of those people who can tell you the difference between Avicaz and Zerbaxa or what the components are. It's a hard time even for me to pronounce them. But as a hospitalist, I do know what to do when I see a patient who might have an infection. But sometimes I can actually diagnose and treat infections. And so you might be asking, with all of this starting me off saying that infectious diseases was never my specialty to begin with, how on earth did I become someone who does antibiotic stewardship work? And so the story I have to tell you actually starts with one of the first conferences I went to. I actually went to an infectious disease conference, and I remember to this day, I was being walked around by someone who was an ID physician who is very, very high up in the field, and I was doing a year as a hospitalist myself, and we came across this conversation which I know my colleague was very sad that I got to overhear because it was two ID physicians complaining about hospitalists and how bad they were at doing stewardship. And they, of course, then got to be introduced to me. Hi, this is Valerie, a hospitalist that you just spoke about in front of. But, you know, it's not just hospitalists that get a bad rap for things around stewardship. Pick your person, and there's somebody that they're going to blame, right? Maybe it's surgery. Maybe it's emergency medicine. That's who I like to blame. Maybe it's nursing. There's always somebody who we're like, if only we could teach them to do better, if only we could give them more education, oh my gosh, that would fix the situation, if just they knew more. But the answer is never, right? The answer is never. If only somebody knew more, then we could get them to do something, right? We're all trying to do the right thing for whatever patient we're taking care of, whether that's, you know, get them the right test, get them the right treatment. And knowledge is like one small piece of the puzzle, and there's so many other things that go into this complex problem, right? We have competing priorities. So, you know, for me, antibiotics are one small fraction of what I'm thinking about in a day when I'm taking care of patients with multiple different things. We have anxiety, and you know, people talk a lot about defensive medicine. I think it's less anxiety about we worry about being sued, and more just like we want to go home and have a good night's rest and not be worried that something bad is going to happen to our patient because of something we did that day, right? So there's the worry that we have about our patients. There is this concern about patient satisfaction. We get those metrics all the time about, you know, how likely is your patient to refer or to recommend your hospital to another patient. And then there's diagnostic uncertainty. And that's true for anything in medicine, but particularly true for infections where our diagnostic tests leave much to be desired, and we're stuck trying to interpret tests that really have been proven to detect infection or to detect the presence of bacteria or viruses, but not to tell us what to do with that information. There are a lot of cognitive biases. I really love studying the psychology of how people make decisions, and it turns out clinicians are people as well, and we make decisions based on a lot of cognitive biases. And then there's the time and the money, right? We got a whole lecture today about the money. The money also trickles down and matters to everybody else because we think about that as well. We think about how do we get patients out of the hospital so that we can reduce that length of stay, save beds, but also the time. And there have been interesting studies that show that later in the day you're more likely to get prescribed antibiotics because clinicians think that's a quicker way to get you to leave their office, to get home to their kids. So if you're somebody who wants antibiotics, you should go at the last appointment of the day. If you want a fresh physician who's going to help you make informed decision making, maybe the first appointment of the day is the right one to sign up for. So there are all of these things, and it's so much fun to think about all of these, and you could apply this to many different fields, and I just happen to choose to apply this to antibiotics because I think all of these things really apply to antibiotics and antibiotic stewardship. So let me tell you about just one of the cases that we get in a typical day of being of taking care of patients. And I'm sure that many of you have seen patients like this. They're often patients coming from our nursing homes. And in fact, this is an 80-year-old woman with dementia who presents for altered mental status, our most favorite of the diagnoses. And the reasons that, again, I told you I like blaming the emergency medicine clinicians. Their most common reason for admitting a patient to us. And what always ends up happening is the patient comes in and they're like, we have no idea what happened. The nursing home's not on the same EMR as us. We have some like hand scribbled notes from the paramedics that got given to the emergency medicine clinician who then lost them. Again, I told you I like blaming ER. By the time they get to us, we have like third-hand information about what happened to the patient. And so we try to call family, can't find anybody, and basically all we have in front of us is the patient who's completely unable to provide any story and maybe even unable to follow an exam. So we're trying to listen to their lungs while they're talking, or maybe talking incoherently. And all we know is that they're not oriented right now, and we don't know what that looks like compared to usual. And of course, before we've even seen them, the ER clinician, thanks again, has already ordered some tests. And because patients coming from a nursing home, 50% of them already have a positive UA if you were just randomly look at them. Of course, the UA is positive, the culture is pending. And if this were a perfect case like you might get in boards, you might see a chest x-ray like this, where you're like, okay, great, we solved the problem. It's a left lower lobe pneumonia. I know how to treat that. And instead you get something like this. And then suddenly you're like, I have no idea what to do. And so, what's the typical next step here? And there are all of these things that you could think about doing, hopefully not giving up, because medicine was never supposed to be this hard. But the answer is that there's not actually like a single right answer in this situation. Whether it's, again, I'm just teasing, I have a lot of friends that are emergency medicine, but for them too, like there's no right answer in a situation like this, right? If you look through studies, some of them will say, well, if the chest x-ray wasn't great, you should get a chest CT. But then again, administration is telling you not to over-order chest CTs. Antibiotic stewardship is definitely telling you not to give vancomycin and probably not to give ceftriaxone either. But then your night team colleagues probably aren't too happy with you if you ask them to go back in 1 to 2 hours and see how the patient is doing. So there are pros and cons of each of these approaches, which makes them all really hard. And so the reason that I like thinking about discharge or care transitions when people leave the hospital is because it's actually way easier. When people first come into the hospital, diagnostic certainty is really low. You've never met this patient before, you don't have a great history, you don't know how they're going to do with a little bit of time. And risk is potentially high, because if you make the wrong decision and this patient gets septic overnight while you're not there and the night team is covering 30 other patients, things could go really bad really quickly. But a few days later, if your patient wakes up and says, I never went Ambien again, that medicine really wrecked me, then you have a little bit more time, you have a little bit more diagnostic certainty. You say this was probably the Ambien, this was probably not that positive urinalysis or the weird chest x-ray that I got, this is probably the Ambien. And you also know, because the patient's doing a lot better, she's sitting up, she's talking to you, that the risk of something bad happening to her is relatively low. So I actually think that discharge is a great time to reconsider and rethink about things. But I talked to you guys about biases. Diagnosis momentum is a huge bias. And basically, we have this in our normal lives as well. Like, once we've made a decision, it's really nice just to stick with that and never think about it again, because it's work to go back and reconsider that. And the idea in medicine is that basically once you make a diagnosis, even if it's under great uncertainty, even if you weren't sure about it to begin with, it's rarely overturned. And this is even more true if there are lots of handoffs. Because what's really funny is if you actually were to go back along that line and ask everyone who saw the patient, if you were to ask the person sending them from the nursing home, the emergency medicine physician, the hospitalist, the night team, and then the hospitalist that took care of the patient the next day, they'll all say, I had no idea what was going on. That's why I sent them to the next person. But then if you ask the next person, they'll be like, well, I assume my colleague knew something, and that's why they started the antibiotics. So we always assume that even if we don't understand what's going on, that there must have been a good reason that someone else did something. There's rarely a great reason, right? We all have a lot of diagnostic uncertainty. It's just not communicated well between people, and we actually really like to give our colleagues the benefit of the doubt, even if our colleagues would readily tell us, no, 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 please, think about this more. That's why I sent them to you. I wanted you to think about this. So there's a little bit of a failure of communication in those kind of circumstances. And then for antibiotics in general, there's this treatment momentum that happens. And the number of times that I've heard my residents say, well, I don't think that they have a UTI, but they've already gotten a day of antibiotics. Let's just finish the course. And it's like, what? You know, like we would never do that with anything else. Say like, well, I don't think it'll help, but why don't we just finish it since it already got started? So they didn't need the first dose, so why don't we give them 4 more? So let's talk a little bit more. So here's what I'm going to talk about today. That's kind of my intro into why I love this and why I think it's really cool to talk about. But I'm going to go through quantifying how we define antibiotic overuse at discharge, including thinking about some high priority areas. I want to talk a little bit more, because I love the cognitive piece of it, about some of the reasons for overuse. Talk a little bit about what we know works and what we know doesn't necessarily work. And I'm going to introduce a framework that we've constructed to help people think about how to approach this problem at their institution. And that's by introducing the Road Home framework, or reducing overuse of antibiotics at discharge. Okay, so let's start by quantifying things. So I, since 2017, have been working, even though I'm now at the University of Utah, working with a collaborative of 69 hospitals across the state of Michigan through the Michigan Hospital Medicine Safety Consortium. And that's where pretty much all of the data for the rest of my talk is going to come from, just so you know where it's coming from. But the beautiful thing about this collaborative is, as you can see from the picture, it includes hospitals from across the state, from the large academic medical centers clustered down there in the southeast part of the state, all the way up to that tiny hospital that's like a 9-hour drive away, that's a 50-bed hospital where they have no ID physicians, no ID pharmacists, and no access to tele-ID either. So, you know, you just see that there's a wide variety of hospitals with different infrastructure. And we came together as a collaborative quality initiative to try to improve care of hospitalized patients. And we actually have multiple initiatives, but one of them focuses on antibiotic use, and specifically improving how positive urine cultures and community-acquired pneumonia are treated across the hospitals for non-ICU medical patients. And to date, we have more than 70,000 patients in each group that we have data on, and we do dedicated medical record review across the hospitals so that we get things like signs and symptoms and discharge prescribing, which it turns out is crazy hard to actually get electronically. So we have all of that, and that data has helped inform kind of how we think about discharge prescribing. And so the very first place that we kind of got into this was actually looking at pneumonia and saying, well, what's the easiest thing we can actually measure in pneumonia? And it turns out it wasn't the easiest thing, but we thought it was going to be the easiest thing, was to measure duration and just say, well, what percentage of patients with pneumonia are getting an appropriately short duration? And what we found is that across hospitals in Michigan, about 2/3 of patients received an excess antibiotic duration. And we defined excess very complicated. I'll give you some less complicated rules in a second. But the important thing was we found that excess duration was actually associated with patient harm. So every excess day of treatment was associated with about a 5% increase in the odds of antibiotic-associated adverse events. And then the thing that kind of changed the direction of what I decided to spend the next 6 years of my career studying was that we found that 93% of excess duration occurred at discharge. And the reason that this happens is because if you think of your typical patient with pneumonia, the median length of stay nowadays is 3 to 4 days, depending on the hospital. So if the average the average duration of therapy for an antibiotic course is 7, 10, 14 days, most of that is happening after the patient leaves the hospital. So that's why, but this is kind of an aha moment, which really changed the way that we started to looking at things, because if you wanted to fix this problem, you were going to have to look at what happened at discharge from the hospital. And so that started us in actually trying to quantify overuse at discharge across multiple conditions and not just focusing on duration. And we decided to focus on 3 types of antibiotic overuse. Unnecessary, which is basically the patient didn't have an infection. Maybe they had asymptomatic bacteria, or maybe they had heart failure that someone decided antibiotic therapy would treat well. And so that's unnecessary antibiotics. The next was excess duration, which I already talked about, and then avoidable fluoroquinolones. And this is when an antibiotic was needed, the patient had an infection, but a safer alternative to a fluoroquinolone could have been used. And so just to briefly touch on unnecessary antibiotics, I think we just had a paper that came out a couple months ago in JAMA Internal Medicine, which really we've spent years trying to define what is pneumonia, which it turns out if you get 20 smart people in a room and ask them to define pneumonia, you'll get 30 definitions of pneumonia. But what we were able to do is actually define what pneumonia is not. And so I actually think more than 1 out of 8 patients is misdiagnosed, but this is the ceiling that everyone in the room could agree upon. These were patients who had no symptoms of an infection, or they had absolutely normal chest x-rays and chest CTs, right? So the patient had no evidence that they actually had a pneumonia infection, and they were being treated with, of course, full course therapy for pneumonia. There have also been other studies that we didn't do, but that others did, that have found that about 39% of hospitalized patients with heart failure are treated with antibiotics. As you may or may not know, many antibiotics also contain salts in them, so this is not a great approach actually to treat a heart failure exacerbation. And they found that antibiotic treatment was associated with more IV diuretic use and therefore a longer length of stay. So a good population to target. And then higher readmissions as patients were leaving with more volume on board. And then I promised you I would tell you what the right duration is. This is actually in flux. I'll say that for pneumonia, generally the answer is always it depends in medicine, but at least 90% of patients that are not kind of taken care of with like the worst of the diseases, right, having empyema, having staph bacteremia, in the ICU, ventilated, can receive 3 to 5 days. There's actually just a great randomized trial that came out that said if a patient is clinically stable, by day 3, you can stop the antibiotics, and they found that outcomes were great with doing that. And if patients are still unstable at day 3, but they're fine by day 5, you could stop it then. The right answer in the future is probably going to be whenever your patient gets stable, you can stop antibiotics, because that's kind of where we're going here. So anyway, right now, the right answer for most patients is somewhere between 3 to 5 days with longer durations for complications. UTI is far more complicated, and I'm not going to approach it because there are new guidelines coming out this year, which I think are going to simplify things. But leave it to say it depends largely on how much the infection has progressed outside of the urinary tract system. So do you have symptoms like fever or bacteremia? And then also what antibiotic specifically you're using. And like I said, hopefully it'll be becoming simpler this year as the new UTI guidelines are I think under review and supposed to be coming out here soon. Then why fluoroquinolones? I probably don't need to say this to this audience, but I just think it's helpful to know that there have been studies that have shown that up to 27% of patients who receive a fluoroquinolone have a side effect from that event. They're a huge driver of C. difficile infections. And one of the things I really like to point out is there was this interesting study in the UK that showed that if you decreased fluoroquinolone use, you actually decreased the amount of resistant fluoroquinolone urinary isolates in the community. So this is definitely a thing where there's the community level impacts can be monitored. And then there's obviously the impact with C. difficile. And then, and I had to change this and add this text because it's actually no longer the most common antibiotic prescribed at discharge, because I think everyone's gotten the memo. I will say amongst our hospitals in Michigan, there are still some outliers who love their fluoroquinolones, but I would say 90% of hospitals have moved on and now use mostly safer alternatives to fluoroquinolones. So this is a big one to focus on if it's a problem at your institution, but actually most institutions are doing a lot better now. So that's great. I think this is actually a success of stewardship and public health campaigns nationwide. So if you look at all of those types of overuse and you look at urine cultures or pneumonia, what we found is that 57% of patients with pneumonia have antibiotic overuse at discharge, and about 40% of those treated for a UTI have antibiotic overuse at discharge. So this is not a small problem. It happens for a lot of patients. And we know that that is associated with harm. We already know about side effects and resistance, but there have been also some interesting studies that show when this happens to long-term care, it increases the risk of 30-day emergency room visits and 60-day C. difficile as these patients are going on antibiotics into long-term care or skilled nursing facilities. And then one thing that I think people are starting to try to measure now is actually especially with this move to get people from IV to oral therapy, or maybe it turns out they didn't actually need the antibiotics at all. Are you treating their ESBL UTI that's really asymptomatic bacteria with IV antibiotics when they could otherwise go home? I think there actually is a kind of untapped way to measure some of the harm here of patients going to nursing facilities that don't need to be there at all because they actually don't need to be on those antibiotics at all. So I think that's kind of a next direction for people to look at, but I think people are really starting to think about that. If you look at this and how it varies across hospitals, so like I said, we have a very diverse group of hospitals that we look at. You can see that there's variation across hospitals, not just in the percentage of patients with overuse at discharge, but also the type. So green here is excess duration, which is the most common type of overuse at discharge. And then red and blue are types of fluoroquinolone overuse. And so you can see, like I said, that most of our hospitals are actually not big fluoroquinolone users, but there are a couple there that have really high fluoroquinolone bars. So what that means is I think you should target different strategies to different hospitals. And interestingly, this is one of my favorite slides. So each circle here is a hospital in our collaborative. The x-axis is the percentage of patients treated for a UTI who have overuse at discharge. The y-axis is the percentage of patients with pneumonia who had overuse at discharge. And there's an 85% correlation here. And what this means is it literally has nothing to do with the patient about what they're treated with or how long they're treated with. This is 100% a facility effect. So if you go to hospital A, you're going to get 5 days, and if you go to hospital B, you're going to get 12 days, and it doesn't matter if you have pneumonia or UTI. People have a duration that they love, they have a drug that they love, and that's what they're going to use. And that's really what we found here. So figure out what it is for your institution and hopefully help kind of move these numbers. And this gives me hope that if you target one condition, it'll have flow over effects to another. So if you convince people that 5-day duration for pneumonia is safe, they might start prescribing shorter durations for skin and soft tissue infection and for urinary tract infection as well, without you having to do a lot of work targeting that. So anyway, that's the optimist in me thinking about these kind of data. And then the other thing that's really interesting is I think there were a lot of people who said, well, we don't have to worry about discharge because we're doing so much on the inpatient side. I'm sure it carries over to discharge. And we found that that was not always true. So we looked at hospitals in our collaborative who were targeting fluoroquinolones on the inpatient side, either through audit and feedback or post-prescription review, and found that those hospitals did a great job of reducing inpatient fluoroquinolone use. So if the hospitals were doing one of those two things, they had less fluoroquinolone use on the inpatient side. Those hospitals had double the number of patients newly being started on fluoroquinolones at discharge. So they hadn't convinced the clinicians were still doing what they wanted to do as patients left the hospital. So after being treated on their cephalosporin during the hospitalization, they were being switched to Cipro or Levo at discharge. So this just shows like if your eye's not on the ball, you're not necessarily gonna see problems that might be happening that you don't know about. Okay, so that's a lot of like what's going on. The question is why. So let's go back to kind of our model, and I said I liked the psychology of things, so let's talk about a couple of cognitive biases real quick. The first one, let me take you back to that paper where we looked at duration, and we said, well, what should people be getting at discharge? And what we found actually is that the vast majority of patients, those who had already completed 5 days of hospitalization, needed 0 days of antibiotics as they left the hospital. Another percentage needed 1 day. I've never written a prescription for 1 day of a drug before, so I can imagine that might be a little difficult. 2 days or 3 days, right? So the doses that people actually needed were very small. What people got was 5, 7, and 10 days of antibiotics, right? So this is what the distribution looks like. And in fact, we found that there were a couple really low-performing hospitals, and we went and we looked at their order sets and found 5, 7, and 10 days of antibiotics to be the automatic buttons they could click to prescribe antibiotics on discharge, right? So the intervention we actually had this hospital do was just delete their radio buttons and make someone input a number, and they actually moved from one of our worst performing hospitals to one of our middle, it didn't fix everything, one of our middle performing hospitals within 6 months. So sometimes it's actually that we're nudging people in the wrong direction. So this is an example of what I would call poorly done choice architecture. So choice architecture is anything that like influences us to make decisions. And this was that somebody at Epic was like, yeah, it seems like a good idea. And the this happen. So, other cognitive biases, we talked about diagnosis momentum. Just to give you some numbers around that, 88% of patients misdiagnosed with CAP in the ED are still on antibiotics 3 days later. So again, this idea that we don't overturn our colleagues' decisions, and that number is about 79% for patients misdiagnosed with UTI, so those who had asymptomatic bacteria. So patients almost always get a full course of antibiotics if they're started on it for one of these two conditions. So let's talk a little bit about the worry and liability piece, and maybe less about the liability, because like I said, I would love to think that we don't think as much about being sued as we do just worry about the safety of our patients. So we actually took clinicians in Michigan and we gave them a vignette of a complicated patient with pneumonia, someone who wanted to leave the hospital, but if the hospitalists had had their way, they would have kept them another day. And we said, okay, what are you going to prescribe to this patient on discharge? And the correct answer was that they needed 2 more days to finish a 5-day course. But we randomly provided them with more information. We said either the patient lived nearby and had follow-up with a PCP within 1 week, or they lived 2 hours away from the nearest hospital and were unable to see their primary care physician for 2 weeks. This goes back to the skin and soft tissue infection, and if you didn't have a PCP, you ended up hospitalizing the patient more. Well, the same thing is true, that if the patient doesn't have good follow-up, you end up giving them more antibiotics. So 88% chose the right answer if the patient lived nearby, but only 63% chose the right answer if the patient didn't have good follow-up, and that was statistically significant. So these factors, and it shows that there's bias. This means that the clinician thinks that it's safer to prescribe a longer antibiotic course, even though the data don't support that. So it's both that we're worried about people and that we think the best thing to do is to do more. That's actually something called the action bias. So the action bias is if we have the choice of like doing something versus not doing something, even if the doing something might be more harmful, we're more likely to do something because we all as humans hate not doing something. We also found that in short stay units, there is even more antibiotic misuse. So this is one of our observation units. 82% of patients had antibiotic misuse. It was often actually, this time I'm not blaming the ER colleagues, but blaming all of my infectious disease colleagues, but 27% of the time it was because a consultant actually recommended the misuse. 18% of the time it's because people didn't account for source control that had happened and shortened durations because of that. And then a lot of time it was actually because people just don't do a great job of counting, right? So this is actually when our pharmacists, I feel like they do so much for us, but sometimes it's just that they're better at counting than I am. So the number of times though that people really thought that like 3 + 3 = 4, it's just incredible, some of the counting mistakes that you'll see. And a lot of people have tried to do actually just better jobs of presenting this information to make it easier to count. And I think that's, instead of expecting busy people to hold numbers in their head from multiple different screens, trying to bring all of that information together on one sheet is really helpful. So let me run quickly through what we have found to be helpful and a good framework for helping facilities think about how to try to improve antibiotic use at discharge. So we know that there are a few things from published literature, mostly quasi-experimental studies, that work. So one of those is prospective audit and feedback at the time of discharge. And this can be done by an ID pharmacist, it can be done by a clinical pharmacist, or it can be done by a transition of care or discharge pharmacist. They've shown different ways of doing this, and those people need different support, different algorithms to help them. You can also restrict certain antibiotics. The VA actually did this for a while, and the VA has one of the lowest amounts of fluoroquinolone use at discharge. So if you restrict fluoroquinolones at discharge, lo and behold, people prescribe fewer of them. You can also do order sets that have automatic de-escalation. So we have this at the University of Utah. You can see here that it took a lot of work to get people to use the order set, which is often the first barrier. But what we have is that patients get a single dose of ceftriaxone, followed immediately by de-escalation to amoxicillin, which people get for 2 days, because we're on the 3-day bag wagon, 3-day total. So this is what we do at the University of Utah, and it's reduced our length of IV and total antibiotic therapy, and also showed a 20% cost reduction, in part because we were able to show actually a reduction in length of stay with this. It turns out when patients with pneumonia are in the hospital and no longer receiving antibiotics, you feel like, oh, maybe they should be able to go home. And so we found that these people actually were discharged sooner as well. But those strategies don't work for everybody. And I'm sure you were looking at that list and thinking of a million reasons why they wouldn't work for you. Maybe your hospital or your facility doesn't have any ID pharmacists. Maybe your clinical pharmacists are already saying, you know what, I'm way too busy. Please don't make me do discharge stewardship as well. Maybe you can't afford a transition of care or a discharge pharmacist. I know one of the major medical centers that I work with actually just laid off a lot of their discharge pharmacists as a cost-saving technique, which I disagree with, but it does make having them do audit and feedback difficult if they're no longer working there. And then restriction, you know, that's really hard too. Utah is a place, you know, we're the Wild West, we're mountain people. We like our autonomy, and you definitely cannot restrict physician autonomy. And so culture at our hospital would never allow you to restrict any antibiotics. So there are many places where that actually would not be a successful strategy. And most of our hospitals don't have a problem with fluoroquinolones anymore. So great, you actually managed to restrict fluoroquinolones, but that's not a problem for you. And then what if your clinicians don't like order sets, or you don't have one of the major EHRs and you're trying to work with a poorly functioning EHR? I won't mention any names there, but you know, there are some where the order sets maybe don't work as well to help you with some of the things that I've talked about. So what do you do then? Turns out one size doesn't fit all for stewardship. I think this has been really helpful and important for us to understand, and made us kind of create this framework. And what we did was actually create 3 tiers of potential strategies, and we applied these tiers to the hospitals in Michigan and found out how many of each of the types of strategies hospitals are doing. And we found that there are many potential pathways to getting to good antibiotic stewardship at discharge. So let me talk a bit about that. So the first tier was what we called critical infrastructure. This meant that you had dedicated stewardship resources, which we were at all of our hospitals had a steward by the time we did this study, thanks to Joint Commission Brex. Hospital policies, guidelines that had been updated in the prior year. About half of our hospitals had some form of guideline period, and then about 25% had the guidelines that had been updated in the prior year. And then almost everybody said that they did education. The quality of education probably varies, but almost everybody says that they do it. What we found was that critical infrastructure by itself was not sufficient, but it was a good baseline to help inform appropriate discharge prescribing. We then said tier 2, which layers on top of that, are stewardship interventions that focus on inpatient prescribing with potential trickle-over effects. I've always shown you that the trickle-over doesn't always work, but maybe there's a way to proactively think about discharge during the normal stewardship activities that you're doing. So for example, if you're doing audit and feedback, maybe you can say, hey, by the way, now that you're going to transition this patient to less broad therapy, when you finally send them out, can you make sure they get no more than 5 days total duration, right? So maybe there's a way to proactively do some things here. And then there are the tier 3 interventions. These are the discharge-specific interventions that are focused on what people do at discharge. These are the things that all the studies focus on. But you can see based on our numbers that nobody's actually doing any of these things, right? So 5% have data at all on antibiotic use at discharge. It turns out that it's really hard to get data. And only 8% of people have a process in place for a pharmacist or somebody to review antibiotics at discharge. So what this told us was that we can't rely on that being our own strategy, because that usually means we have to hire somebody else to start doing more audit and feedback, and that's hard. What we found, though, is that there are multiple ways to improve antibiotic use. And actually, we did this complex model that actually showed that a tier 3 intervention is about 3 times as effective as a tier 1 intervention. A tier 2 intervention is about 2 times as effective as a tier 1 intervention. But what that means, and we gave them all kind of points, is that you could, instead of doing a tier 3 intervention, you can pick and choose what you want from tier 1 and tier 2 and like say, you know what? Instead of doing a tier 3, I'm going to do one thing from tier 1, one thing from tier 2, and that's probably going to be as good as a tier 3 intervention, but potentially more feasible for your hospital. So I like this as a choose your own adventure, pick 3 points and go in that direction, whatever works for you. And that's what we found, is that there are different strategies. There are some hospitals that were able to do it all. I'd love to work at one of those hospitals. There were some, and particularly our smallest places, found that actually doing a tier 3 intervention was the easiest thing, because if you only have 50 beds, that means you only have 7 people being discharged a day, only half of them on antibiotics. Hey, I can review 3 people a day, right? So they actually thought that those tier 3 interventions were the easiest. And then a lot of our large systems that had a lot of patients said, you know what, I'm going to integrate discharge stewardship into what I'm already doing on the inpatient side instead of building additional workflows. And so that's just to show you here what those hospitals look like. This was a do-it-all hospital. This is one of our hospitals that said, you know, I'm just going to focus on the inpatient, but talk about discharge during those things. And then this is one of our tiny hospitals that decided to really hone in on discharge stewardship. And you can see that they're all doing relatively well, but have different pathways of getting there. So if you ask the question, what's the most effective strategy to improve antibiotic prescribing at discharge? The answer is it depends. I say that for all things in medicine. It's true, I think, for all things in stewardship as well. It really depends on the hospital or the institution context and what you're able to do and what you're already doing. Are you able to incorporate discharge into something that you're already doing rather than build something new? And we're actually testing this strategy in a cluster randomized hospital where we're having hospitals choose 3 points of interventions that they're going to do, but allowing them to choose that based on what's feasible for them. And it's been so interesting because if you ask people, you know, rank on a scale of 1 to 7, what's the easiest for your hospital? Nobody has the same ranking. So what's easiest for hospital A is not the easiest for hospital B, and in fact, it might be inverted. And so, and it often depends on who you ask. If it's going to be a pharmacist that's leading the intervention, they actually tend to think that doing a little more audit and feedback is going to be the easiest. Whereas you ask a clinician, they might think that changing guidelines is going to be the easiest. So it often depends too on who's doing the intervention and then where they're doing it. So in summary, clinicians make decisions under a great deal of uncertainty and experience complex influences rarely related to evidence. And I think that's important to keep in mind when you're thinking about how to change behavior, is that prescribing practices are rarely based off of knowledge, and therefore education is rarely going to be the intervention that fixes everything. Antibiotic overuse at discharge is common. The types of overuse we talked about today were duration, unnecessary use, and avoidable fluoroquinolones. And that's often related to cognitive biases, nudges, or poorly designed choice architecture, diagnostic momentum, and fear of care transitions. I talked about hospital discharge today, but that's true. Leaving nursing homes, going hospital to hospital, people are just afraid when you're sending patients out into the relative unknown. And we know that overuse of discharge it causes harm, both antibiotic side effects, C. diff, and then I think this interesting area to explore is the unnecessary IV antibiotics and potentially the unnecessary discharge to a skilled nursing facility when the patient doesn't even necessarily need the antibiotics. And then you could use the road home framework to help pick strategies likely to be effective for your individual context, because no two strategies are going to work the same for every institution. Tier 2 interventions are where you kind of proactively consider doing discharge-related activities, but during your existing inpatient infrastructure, your inpatient stewardship. And Tier 3 is dedicated discharge stewardship activities, and all of those are bolstered by strong stewardship infrastructure. So one of the first things we always tell people to do is, do your guidelines actually say to do 5 days for pneumonia? If they don't, it's going to be hard for you to build an intervention on top of that that says we're doing 5 days for pneumonia if a clinician can say, well, your guidelines say 7 days, right? So that's, the infrastructure is key, but often insufficient by itself. If you want more information on the framework, I have the reference up here, as well as information about the trial we're running. I'm also happy to answer questions. Thank you.